Hello, everyone. My name is Vita Kessler, and I'm the Operations Manager for Capstone Performance Systems, and I'm very glad to welcome each of you to our ICD-10 webinar series. Today is the second of 6 presentations we have planned for this series. We are pleased that we have over 150 registered for today's presentation. Remember that you will need to register for each session if you didn't already. The webinars will be recorded and available for download from our website, www.capstoneperformancesystems.com, by navigating to the ICD-10 Support tab on the top menu. Handouts are also available on the Start Meeting Event webpage in PDF format, which includes a copy of today's presentation slides and also the previous webinar handout. Capstone is pleased to sponsor the series for our PACE clients, friends, and the larger PACE community. We have been helping PACE organizations to improve documentation, compliance, and revenues for over 10 years and have had the pleasure of working in about 2/3 of the programs in the U.S. We've learned a lot over these years and hope to share some of that with you over these next few weeks. We also recommend that programs and providers take advantage of many available resources in your local health systems and through online programs to learn about ICD-10 and documentation improvement. Repetition is key. Capstone also offers additional training and support to our clients, so feel free to contact us if you have any questions about our services. Our goal in these webinars is not to make coders out of primary care providers or others. We understand that many EHRs require that a PCP select a diagnosis code as part of the encounter documentation, but we have seen this leads to lots of errors in coding. We do think that by learning some of the material in this series, providers will become more adept at ICD-10 coding, but more importantly, we want providers to understand how coders think, to recognize the guidelines that inform their thinking, and to become cognizant of the mental shifts that are necessary to best meet the documentation requirements of ICD-10. Also, during this presentation, if you have any questions, please press *6 to be entered into the question queue, and we will try to answer these in order in the time we have available. I now want to introduce Andy Ladd, RN and Certified Coder, who is head of our coding department here at Capstone.
Good afternoon, everyone. For those of you who joined us last week, I would like to welcome you back. If you are joining us for the first time this week, I would like to introduce our guest presenter, Pat Sherman. Pat is a registered health information administrator with the American Health Information Management Association. She is also a professor in the Health Information Technology at St. Louis Community College, where she teaches ICD-10. Pat and I will be joint presenters for today's webinar, focusing on documentation for diabetes, vascular disease, CKD, and neuropathy. Pat, would you like to get started?
I certainly will. And welcome to everyone, and good afternoon. I'm going to present a summary overview, much more condensed than our very first presentation, just to remind everyone that the changes from ICD-9 to ICD-10 have increased in code capacity from 14,000 to about 75,000. Also, a significant change is an increase in the specificity. For example, we're now able to code right, left, and bilateral in ICD-10. The code structure now begins with an alphabetic character, and there are 5 to 7 characters in length. For example, for non-displaced fracture of the lateral malleolus right fibula, initial encounter for this closed fracture, we have code S82.64XA, A being the character for initial encounter. And we also have tobacco exposure requirement. I believe that's a Z5731. And there's also one for environmental exposure. So this is new for 10, along with combination codes. For example, diabetes with complications there's one code now. And if there is polyneuropathy with it, it's an E11.42. We also have encounter coding. And this is an area where we're able to use a seventh character for initial encounter, a subsequent encounter, or sequela. Angie, would you like to expand on encounter coding at this point?
I would. What I would like to do is explain a little bit about this because this is so new and it is going to be required. Most of these are going to be for the injury codes, which is in Chapter 19. These are most of your fractures, so I think this is important to point out. So the initial encounter coding, basically what this means is this is the first encounter for active treatment. This would be something that was like an emergency department visit, surgical treatment, or an evaluation and management by a new provider. Let's just say you have a fracture, you send them to the emergency department, and they have diagnosed as a fracture. They have fixed this fracture. Let's just say it was a hip, and they are now going to send them to the ortho for their first eval. That would all be encompassed under the initial encounter. The subsequent encounter is, what that means is it doesn't mean that it happened again. It means that this is for routine care for injury during the healing or recovery phase. So you have a fracture, and let's just say you're now 4 weeks out, and they're coming back to you just for a follow-up. That would be a subsequent encounter. The last encounter coding is sequela. Sequela are complications or conditions that arise as a direct result of the injury. An example of this would be scar formation after a burn.
All right. Excellent. Use of the table of drugs and chemicals. This is another new element that will summarize drug underdosing. Intentional underdosing is now coded Z91.128. We also will use a code from the drug table, the T codes, T36 through T50. For example, an intentional underdosing of metoprolol. Initial encounter is coded Z91.182. That's the underdosing, and the specific medication is the T44.7X6A. Today's objective.
I'm sorry. Let me add one more thing. The reason I introduced this, had this example on there, is because a lot of times what I see in the documentation is you have either somebody is refusing to take their meds for whatever reason, or you have a family member that thinks they know everything about medications and medicine, and they're telling their family member not to take the medications. In ICD-9, this was just documented as possibly noncompliance. In ICD-10, it's a lot more involved. You're going to have to say that it's an intentional underdosing, and then you're going to have to say of what it is. So I use metoprolol for the example of, let's just say, hypertension, and they're refusing to take their metoprolol for whatever reason, and they're intentionally refusing to do it. That bottom right there, intentional underdosing of metoprolol, initial encounter, those are the codes that we would use for that. I'm sorry, Pat, for interrupting. Go ahead.
Oh, no problem. Now, today's objectives, we're wanting to review Chapter 4, and Chapter 4 in the ICD-10 codes, endocrine, nutritional, and metabolic diseases. We will specifically highlight diabetes mellitus today. We're going to review the documentation and coding for peripheral vascular disease, including diabetic PVD. We're going to review documentation and coding for chronic kidney disease, including diabetic CKD, and review documentation and coding for neuropathies, including the diabetic neuropathy. So for Chapter 4, as far as I-10 endocrine, nutritional, and metabolic diseases, the range is E00 to E89. This includes common disorders of the thyroid gland, obesity, dehydration, and of course, diabetes mellitus. Other conditions coded to this chapter include intraoperative complications of the endocrine system, malnutrition, metabolic disorders, post-procedural endocrine and metabolic complications not elsewhere classified. The diabetes and ICD-10 have undergone significant changes. The 5 categories of diabetes mellitus compared to the 2 categories in 9. The 249 secondary and 250 were the rubrics in ICD-9. Now let's look at what's offered in 10, starting with E08 through E13.9. The E08 is diabetes mellitus due to an underlying condition. E09, drug or chemical-induced diabetes mellitus. E10, type 1 DM. E11, type 2 DM. The Roman numerals have been deleted in ICD-10. And E13, other specified diabetes mellitus. The significant changes have expanded to reflect the manifestations and complications of diabetes by using a 4th or 5th character rather than using an additional code. For example, in 9, for us to code diabetic neuropathy, we use the 250.60 unspecified along with the 257.2 for neuropathy. In ICD-10, look at the 1 code, E13.40. So ICD-10-CM does not classify diabetes as out of control, poorly controlled, or inadequately controlled. The use of the codes in 10 are used to report uncontrolled status by using the code for diabetes mellitus by type with hyperglycemia. Now, as an overview continues in Chapter 4, the diabetes mellitus codes, combination codes, they include the manifestation. Type 1 and 2 codes contain details about the type of diabetes and most of the associated complications as compared to ICD-9, where few diabetes codes required the use of an additional code for the manifestation. For other types of diabetes, the underlying condition is listed first, followed by the diabetes code that includes any associated complication. For example, E08, diabetes mellitus due to an underlying condition. For this example, such as Cushing's syndrome. E09, drug or chemical-induced diabetes mellitus. Example, steroid-induced. And we would code first category T36 through 65 to identify the particular drug or chemical. So, starting with diabetic complications and manifestations, Angie will take us from here with category E11.
Yes. This is the category that most of you will be working in. This is the category E11. It's type 2 diabetes mellitus with complications. The codes go from E11.0 to E11.8. It includes type diabetes mellitus without complications also, which is E11.9. So while you will see E11.9, if there are no complications, most of what you're going to see is in the E11.0 through E11.8 category. So what I'm going to talk about first is diabetes type 2 with the kidney complications. There's a change in the way we need to document for diabetes with complications. a little further in the webinar, I'm going to give you what you should document and what you should not be documenting. So in the kidney complications, you have first your diabetic nephropathy, which is E11.21. This can include with intracapillary glomerulosclerosis. That's hard to say. The second one would be diabetic chronic kidney disease, E22. There are two categories in ICD-10 that require an additional code. This is one of them. Diabetic chronic kidney disease, you have to state the stage of CKD, which would be 1 through 5, and end-stage renal disease. The last one is other diabetic complications, which could be, a variety of things. It could be with renal tubular degeneration. It could be polycystic kidneys, different things like that. So if you have a category, just because it says with renal tubular degeneration doesn't mean that's the only thing that goes in that category. The main thing to realize is that these are now combination codes, and we are no longer, which I'm going to reiterate this, we are no longer documenting diabetes with renal manifestations, diabetes with neurological manifestations. You need to say what it is. It's diabetes with CKD or diabetic chronic kidney disease. It's actually quite simple. They've made it a little more simple. Okay, so documentation for diabetes with kidney complications can look something like this. The patient presents for a follow-up from a nephrology visit. Blood sugars are now under control and the GFR is stable. The assessment plan is as follows. Diabetes with CKD stage 4. We're going to continue to monitor the GFR and the glucose levels. We're going to avoid nephrotoxic medications and continue to follow up with nephrology. No medication changes at this time. The correct code for this documentation, the correct codes for this documentation would be E1122, which is diabetes with CKD, and also you're coding N18.4, which is CKD stage 4. That's all you need to do for those. You can still say diabetes with CKD, diabetes with neuropathy, but it's, we're trying to get away from we need to get away from the saying diabetes with renal manifestations. So the next category is type 2 diabetes with retinopathy. Your categories are diabetic retinopathy, E11.311 to E11.319. The change here is that you must document with or without macular edema. In ICD-9, macular edema was a separate and additional code, and it didn't matter if you said it, if you said it was without, but you did add the code if you said that the diabetic retinopathy did have it. In ICD-10, you need to state that they have diabetic retinopathy with macular edema or diabetic retinopathy without macular edema. Next category is proliferative and non-proliferative diabetic retinopathy, E1132 through E11.359. Again, you must document with or without macular edema, and also they have added mild, moderate, and severe proliferative and or non-proliferative diabetic retinopathy. The next manifestation or complication, rather, is diabetic cataract, which is E1136. I will caution you on this, as I've said before in different education and trainings. This is a very rare condition. If you do not have it documented, most likely by an ophthalmologist, then I would not recommend documenting diabetic cataract. Just because they have diabetes and cataracts does not mean their cataract is a diabetic cataract. However, if it is, that's the code you would use, E1136. Then you also have type 2 diabetes with other diabetic ophthalmic complications, E1139. Okay, documentation for diabetes with ophthalmic complications. Example, patient presents today with complaints of blurry vision and polydipsia. Finger stick results this afternoon are 350. Blood glucose log checked with blood glucose ranges of 200 to 300. The assessment plan, type 2 diabetes with hyperglycemia and mild non-proliferative retinopathy due to diabetes. No macular edema is present. We're going to increase the Lantus to 35 units QHS. The codes for this documentation would be E11.65, diabetes mellitus with hyperglycemia, noted by the increase in finger sticks, and E11.329, diabetes with mild, non-proliferative diabetic retinopathy without macular edema, you also would add the code Z79.4 for long-term current use of insulin. Now, when I say that, most of that is for a coder. I'm telling you because it's something that I want you to know, because as a coder, when they're on chronic anticoagulation, use of aspirin or chronic opiates or things like that, as a coder, we are instructed to use a long-term or current use of that particular drug. If we see that they're on an insulin, we're going to automatically add that, but I'm using this example because it is proper coding. Okay, diabetes with neurologic complications. You have diabetes with diabetic neuropathy, unspecified, E1140, diabetes with diabetic mononeuropathy, diabetes with diabetic polyneuropathy. These are the changes in 10 from ICD-9. You now have a code for a mononeuropathy, and you also have the code for the polyneuropathy. So when you're doing your documentation, we need to state that. If it's truly a mononeuropathy and not a peripheral or poly, then it needs to be documented. Diabetes with diabetic autonomic neuropathy, E1143. These are your conditions such as your diabetic gastroparesis and your orthostatic hypotension. You will notice, as there are combination codes, we are no longer coding for the diabetic, obviously we're not using the 250 codes anymore anyway, but you wouldn't code, 25060 and 536.3. It's one code. Diabetes with diabetic autonomic neuropathy, gastroparesis is E1143. And your last category is diabetes with other diabetic neurologic complications, which is E1149. I will say that a word of caution, and this was in ICD-9 also, but I really want to make this, hit hard on this for ICD-10. You really need to make sure that your documentation is specific. You probably shouldn't be documenting an unspecified code. They've changed ICD-10 to make it to an unbelievably specified condition, so we need to start documenting that way, because if not, it's just going to cause query after query after query from your coders, and more work for you. So here we go with an example. Documentation for diabetes mellitus with neurologic complications. The patient presents for a follow-up of diabetes with complaints of increased pain to his bilateral feet. He has had diabetes for 30 years and has significant diabetic neuropathy. The assessment plan is diabetes mellitus with polyneuropathy. We're going to increase the gabapentin to 600 milligrams POBID. The code for this, E1142, diabetes mellitus with diabetic polyneuropathy. Okay, the next category is diabetes with circulatory and other complications. This is the other category in ICD-10, the only other category that requires an additional code. As I said, they're all combination codes except for diabetic CKD and the ulcers, and you'll see that here in a second. So diabetes with diabetic peripheral angiopathy, E11.51 to E11.52. You must document with or without gangrene. Diabetes with other circulatory complications, E1159, and diabetes with other specified complications. Before I go to that, I want to go back up to the chalk one, diabetes with diabetic peripheral angiopathy. This is your diabetes with PVD. When I've been dual coding, and I've looked it up a couple ways because I know how the documentation is currently, and I tried to see if there's going to be that much of a difference with the current way you currently document. And what I found is that I believe if you still say diabetes with PVD, it's still going to give you the E1151 code. Okay, diabetes with other specified complications. This category includes diabetic arthropathy, which is E1161, which this should include your Charcot joint manifestations. Your foot ulcer, E11.621, this is where you would use the additional code for an ulcer. So if you have diabetes mellitus with a diabetic ulcer, you would document that, you would code E11.621, and then you would use an additional code for the ulcer, which would be from category L97 or L98. And we will get into ulcers in a couple more slides. So I will expand on that shortly. You have the opportunity for an other skin ulcer, which is E11.622. You also need to use the L97 or 8 for the additional, as an additional code for the ulcer. And then you do have other skin complications, which is E11.628. Okay, documentation for diabetes with circulatory and other complications. The patient presents for follow-up of diabetes and leg pain. On exam, patient with diminished sensation and dependent rubor in bilateral lower extremities. He does complain of intermittent claudication. DP and PT pulses are absent, and there is a 2-centimeter ulcer present on the lateral aspect of his left foot. The assessment plan: diabetic peripheral vascular disease without gangrene. Check lipid panel and start Pleadle 50 milligrams BID. 2-centimeter diabetic ulcer of the left foot, superficial wound. No sub-Q fat noted, followed with wound care nurse. In this example, the codes would be E11.51, diabetes mellitus with peripheral angiopathy without gangrene, E11.621, diabetes mellitus with a foot ulcer, and the ulcer, L97.521, non-pressure ulcer of other part of the left foot, limited to breakdown of skin. Now, as I said, I'm going to explain that a little bit more here in the next couple slides because it is changed from ICD-9. Okay. Examples of ICD-10, of diabetic ICD-10 CM coding. These are just some more examples. Type 2 diabetic patient evaluated for chronic diabetic left foot ulcer with necrosis of muscle. The patient takes insulin on a daily basis. The coding would follow. E11.621, diabetes with foot ulcer. Code for the ulcer, L97.523, using the degree of necrosis of muscle, and again, long-term use of insulin, B79.4. Here's an additional example. Patient is seen for diabetic chronic kidney disease, stage 3. The patient has type 2 diabetes and takes insulin on a daily basis. The appropriate code assignments would be E11.22, type diabetes mellitus with diabetic chronic kidney disease, the N18.3, which is chronic kidney disease, stage 3, and again, long-term use of insulin or current use, B79.4. Additional examples, this patient is a 42-year-old male, poorly controlled type 2 diabetic with diabetic stage 3 chronic kidney disease, hypertension, and mild non-proliferative diabetic retinopathy without macular edema. E1165 is where your poorly controlled diabetes mellitus is. But in this example, I recommend using hyper or hypoglycemia. Most likely it's going to be hyperglycemia, but we really need to get away from using uncontrolled or poorly controlled because that is no longer a code. It must be coded for hyper or hypo. E22 or E1122, type 2 diabetes with diabetic chronic kidney disease, and the additional code for the kidney disease, N18.1 to N18.6, which in this case it would be N18.3. The I12.9, hypertensive chronic kidney disease with stage 1 through stage 4, because they have hypertension and kidney disease, and by guidelines you can assume that relationship. As I said, the chronic kidney disease, and then E11.329, diabetes type 2 with mild non-proliferative diabetic retinopathy without macular edema. Okay, what to remember for documenting diabetes? And I probably already said this, but I'm going to say it again. The coding guidelines that applied to ICD-9 also applied to ICD-10. And what that means is this. You still have to state a relationship between diabetes and any manifestation and or complication of the diabetes. So you still have to relate them. So you still have to say diabetic neuropathy or CKD due to diabetes, or PVD due to diabetes, or diabetic PVD, or something. There has to be documentation that links them. You can't state diabetes mellitus, as diagnosis 1 on your list, and diagnosis 10 says CKD, and it's going to be coded as a combination code, because it's not. And then you're going to lose an HCC, so don't do that. You cannot document diabetes mellitus with neurologic, renal, ophthalmic, or ophthalmic manifestations by itself. So in other words, a lot of times I will see the documentation state diabetes with renal manifestations, and that's it, nothing else. You cannot do that. The documentation, again, must reflect the complications and or the manifestation, and be clear that it is related to the diabetes. So we must continue to document. That did not change from 9 to 10. But it bears repeating. Okay, continuing on. If it is a diabetic ulcer, you must state right or left and document the severity. So here's where this changed. Because diabetic ulcers are typically non-pressure ulcers, well, they'd be pressure ulcers, you're going to look in the L97 category, which is non-pressure ulcer of the right or left, and then the body area. So here are your choices. You have limited to breakdown of skin, with fat layer exposed, with necrosis of muscle, and with necrosis of bone. Pat, do you want to talk a little bit about the necrosis of muscle and necrosis of bone, just so they get an understanding?
Yes. The guidelines are somewhat ambivalent in this area, but I was able to find for the L97, not elsewhere classified. The non-pressure ulcer, left or right, is very important, the body area. But for the associated conditions, it's really important that we, again, get the site, the laterality, and the severity. And, of course, you can code any associated underlying conditions. But the non-pressure chronic ulcers of lower limb include these broad 4 ranges. There are others, but these are the ones that are salient at this point in the L97.
So I think that the documentation must, at this point, present a picture of what this looks like. You all know that you do not stage, technically you do not stage diabetic ulcers. There is no stage 1 through 4 because it's not a pressure ulcer, it's a diabetic ulcer. So the more descriptive you can be with what we're looking at in the ulcer, the better it is. It does say necrosis of muscle and necrosis of bone. It doesn't necessarily mean that it has to be muscle necrosis or bone necrosis. If you have,
that's right.
Right. So if you have a diabetic ulcer and you can see down to the muscle, then what I would recommend is that's what you would document. And then the coder could then, from your documentation, determine what the correct code for that would be. Again, I'm going to state that we can no longer say poorly controlled or uncontrolled. We must now say hyper or hypoglycemia. Documentation tips for diabetes. When documenting for diabetes, you must think of the following, or should think of the following. The type or etiology of the diabetes. Is it type 1 or type 2? Is it drug or chemical induced? So you know now that we no longer have the secondary diabetes category of 249 for those patients that have a steroid-induced diabetes, or maybe they had a pancreatectomy, and those are going to go under one of the other categories for diabetes. You have to think of the body system affected. You have to think of the complication or complications affecting that body system. And as we've educated before, if you have a patient that is a diabetic, you also should be looking for any complication that could be associated from those. If they have other complications, such as PVD, you should be evaluating if the PVD is related to the diabetes. The presence, again, of hyper or hypoglycemia, and also document any insulin use. Most of the time, we're going to pick that up because in your documentation, you almost always state if they're on insulin or not. Okay, do not document. Do not use a slash when documenting diabetes with complications. And the example is as it says, diabetes mellitus / CKD. Do not document, again, diabetes mellitus with renal manifestations only. Actually, there's no point in documenting diabetes mellitus with renal manifestations, ophthalmic, neurologic. Just document what it is. It's diabetes with CKD. It's diabetes with nephropathy. Do not document, and this does not signify a relationship. And the example is below. Diabetes and polyneuropathy, there is no relationship according to ICD-9 guidelines. It means and to ICD-9 or ICD-10, ICD-9 and 10 means separate. Means the diabetes and the polyneuropathy are separate. Also, do not document symptoms. Don't document diabetes mellitus with numbness and tingling because I don't know what that means. I know what that means, but I can't assume that that means they have a polyneuropathy. And we as coders cannot assume anything, so it must state. If they have diabetes with a polyneuropathy, it should state diabetes with polyneuropathy, not diabetes with numbness and tingling. Do document all complications of diabetes, as I suggested. Documenting with does signify a relationship between the diabetes and the complications. And for example, diabetes with CKD. In ICD-10 and ICD-9, with means that two conditions are related.
That's right.
Okay, peripheral vascular disease. Peripheral vascular disease or arteriosclerotic vascular disease or atherosclerosis of the extremities. These categories are expanded to increase the specificity with bypass graft or native artery, which is something that is not new. Technically in ICD-9, you should have stated if they had a coronary artery disease that it was of the bypass graft or it was of the native artery. But now in ICD-10, it's in the coding. You should state that if they have a vascular disease, peripheral, that it is of a bypass graft or it is of a native artery. Most of the time it seems like it's of the native artery. You have laterality in this category. And if they have an ulcer, you must state the ulcer site and the severity of the ulcer. So we're going to see some examples. So the examples are from category I-7020 to I-70.79, atherosclerosis. And here's it. I want you to see how extremely specific it gets. Atherosclerosis of the native arteries of the extremities, right or left leg with intermittent claudication. Right or left leg with rest pain, right or left leg with ulceration, right or left leg with gangrene, right or left leg of the bypass graft with blah, blah, blah. There are over 100 ICD-10 codes for this category alone. In ICD-9, there were 10. So you can see by that tenfold increase how much the specificity has increased in ICD-10. Documentation for peripheral vascular diseases. Patient for follow-up of vascular ulcers presents with complaints of increase in leg pain, now even at rest. On exam, the pulses are absent. Bilateral lower extremities are ruby in color and cool to touch. There is a 5-centimeter ulcer on the left calf with visible subacute fat. The assessment plan, atherosclerosis of the extremities, native arteries, with rest pain and ulcer, refer to vascular surgery. Also, ischemic ulcer, left calf with visible subacute fat, continued wound care. The codes for this documentation is I-70.424 for the atherosclerosis, and for the ulcer, L97.222. One thing I want to mention here is that the I-70 code, if you have atherosclerosis of the extremities, and then the ulcer code would include the rest pain and the intermittent claudication. You don't have to assign, a code for intermittent, a code for rest pain, and a code for ulcer. That just as an FYI. More documentation for peripheral vascular disease. Patient presents with complaints of achiness and redness of legs. On exam, distal pulse is present only by Doppler. Skin remains cool to touch with absence of hair. Venous stasis present bilaterally. ANP, TBD, peripheral vascular disease, bilateral lower extremities. Patient given TED hose and instructed to elevate legs when seated and follow up in 1 week. One code, I-73.9. One thing I will say is that just like in ICD-9, if you say PAD or you say PVD, it still indexes to the same code, which is I-73.9. So if it is what I usually recommend is that if it is arterial, you either state it's arterial or you say peripheral vascular disease due to atherosclerosis of the extremities. That is specifically important when you're talking about an arterial ulcer, as it is a higher HCC than a vascular ulcer. FYI. Okay, venous embolism and DVT, I-82. When documenting for DVT, remember the following. You should be documenting now, and it's specifically when ICD-10. If it is a DVT, you must document if it's an acute DVT, a chronic DVT, or a history of DVT. A lot of times I see that you have acute DVT, and it happened 4 years ago. So then it needs to become chronic. You have to remember also, acute and chronic DVT codes map to HCCs. History of DVT does not. So if it's truly a chronic DVT, you should be capturing that in your documentation. Document right, left, or bilateral. Document upper or lower extremity, and specify which vein, if known. So an example, chronic DVT, right femoral vein, it would be I-82.511. Okay, CKD. This is a quick one. Coding for CKD. Documenting the stage of CKD, not the GFR, is vital for accurate coding. If the stage is not documented, then it codes to N18.9, which is chronic kidney disease unspecified. It is important to document, as I said before, as specifically as possible. If you have the lab work and you have the GFR, then you know what the stage is, so that it should be documented that way. However, as I said, you shouldn't put, you should put the stage. It should say, CKD stage 3, and then you can put the GFR. But if we see GFR of, 40, the coder is not going to automatically assign CKD stage 3 because it's not documented that way, and they cannot assume that. If a provider documents both the stage of CKD and ESRD and stage renal disease, then you only code for the ESRD and 18.6. Here's the codes and 18 categories, and you can see it's pretty easy. It's almost like ICD-9, only it's N18.1 through 6 instead of 585. You would use an additional code with end-stage renal disease and 18.6 to identify dialysis status of Z99.2. So just like in ICD-9, if they have end-stage renal disease and they're on dialysis, you want to make sure you're documenting that so we can capture both codes and get the HCCs for that. You also code any associated disease, which would be diabetic CKD or hypertensive CKD. Chronic kidney disease with other diseases. You have anemia in chronic kidney disease, which would be D63.1. This CKD would also be coded, the stages. You have hypertension with chronic kidney disease or hypertensive CKD, same thing. I-12.9, the CKD must also be coded. Two things I want to mention, which I'm not going to go into detail. This will be covered in another webinar. This does not include hypertensive heart and the CKD, which is a different code. It's I-13. I just want to mention that we will explore that further in probably, I think, the next webinar. Also, there is no ICD-10 code for hypertension with CKD and heart failure. There wasn't an ICD-9. It has to be hypertensive heart. But again, we will get through that in another webinar. I just wanted to bring that up as an FYI because we're talking about CKD. Neuropathy. Coding neuropathy in ICD-10 is very similar to ICD-9, but with more specificity. So upper limb mononeuropathies are classified to category G56, document right or left limb. The comparison to ICD-9, carpal tunnel syndrome in ICD-9 was 354.0. In ICD-10, you have carpal tunnel syndrome unspecified, right upper limb, and left upper limb. Lower limb mononeuropathies are G57. Additional characters identify the specific nerve and laterality. For example, sciatic right or left, femoral right or left, and popliteal right or left. Example would be a lesion of the sciatic nerve, right lower limb, G57.01. Polyneuropathy is classified to categories G60 to G65. Be sure to document, as I said before, if it's a polyneuropathy, if it is affecting multiple nerves, or if it's a peripheral neuropathy. Remember that mononeuropathies do not map to HCC. So, G56, mononeuropathy, no HCC. G57, no HCC. Peripheral and polyneuropathies, G62.9. The interesting thing to me here is that ICD-9, it was 356.9, and it's in ICD-10, it's still an HCC. It's still HCC 75. Like I said, the interesting point here is that in ICD-9, neuropathy, if you only said neuropathy, it indexed to 355.9, which is not an HCC. But in ICD-10, if you just state neuropathy, it indexes to the G62.9, and it is an HCC. So that's just an interesting point I wanted to make. Diabetic neuropathy, this is tricky. It is no longer there is no longer an individual code for diabetic neuropathy as in ICD-9. So in ICD-9, if you said diabetic neuropathy, it was 357.2. Now it's a combination code. It's either E11.40 or E11.42. So that concludes the presentation for diabetes, vascular disease, CKD, and neuropathy. We will now open the floor for question and answer. Remember to push *6 for this function. Hello.
Hi, this is Dr. Gutierrez from St. Paul's Place. Yeah, these are really valuable information that you are giving to us, especially with the diabetes, since it's scored very high with HCC. I printed the webinar material, and I can hardly see it. I tried 2 printers because probably the ink use is very light, like especially the light blue. It is very difficult to read it because I'm sure I'm going to be looking back at this note when I'm doing the ICD-10 because it's so valuable. Is there any way that we can make the printing, darker in color?
You know what? How about if you look at the screen right now, and this is for everybody too. If you have additional questions, you can email them to myself, which I am on the bottom, alad@capstone.com, or Dr. Shamp at rshamp@capstone.com. Why don't you email me your email address, and then I will get you a good copy of that. Would that work?
Yeah, sounds good. Thank you.
Okay, sure. You're welcome. Do we have any other questions on coding or documentation requirements?
Thank you. This is Eric in Lynn, Massachusetts.
Hi.
Regarding the first visit, there's an initial visit when the person first breaks their leg, but
yes.
What about when it's the first time you personally have seen them? it's your first time seeing them, but it's not the first time they've seen a provider. Is there a different code for that, or it's just subsequent?
I guess in a sense it would depend on the chain of events. So let's just say that they were at home and they broke their leg and they went to the emergency department and they diagnosed them with a leg fracture. And then the next day they come to you. I would, in that case, still use the initial because they're still using this is an evaluation and management by a new provider, which would be you. So that is allowed in the first encounter, the initial encounter, rather.
Okay, thank you.
You're welcome.
Hello. Hi.
Hello.
This is Betsy Canino from Pace in Rhode Island.
Hi, Betsy.
Hi. I have a question. Should we find that magical person with a diabetic cataract and it was removed, then would they not have the cataract anymore, correct?
Correct.
Okay.
Yep.
Thanks.
Unfortunately, you have to find another complication.
We fixed.
Hi, Angie. It's Madasha from Wilmington.
Hi, how are you?
Hi. I had a question about, you gave the really good summaries, and then you did the assessment and plan, and in that summary you talked about, for example, for peripheral vascular disease, no hair seen on the leg, or for diabetes with polyneuropathy, where, they don't have two-point discrimination. If all of that information is in your exam, so you got your subjective, your exam part, and then under your assessment and plan, do you have to repeat it there?
What I recommend is this, and the reason why I'm going to say this is because you don't always have a coder that has a medical background. Some of them do. Some coders have strong clinical backgrounds. But in the ICD guidelines state that coders cannot assume a condition. So if you see that they're, like you're describing, like, we're talking about, the legs are ruddy in color, they're tool to touch, there's no pulses, you as a provider in your assessment plan wouldn't need to repeat the findings. What you would say is, okay, based on these findings, I'm stating that they have peripheral vascular disease. Does that answer your question? Does that help?
Yeah. Yeah, so
okay.
We could just say based on about findings, blah, blah, blah.
Yes. Yes.
Okay.
And that's for anything. I mean, you are the provider. You are, the one who is, has all the knowledge to make these decisions. CMS does not state that your diagnosis have to be spot on and correct. They just have to say that using your medical knowledge and your medical background, you are making the diagnosis based on what you're seeing, and whatever that happens to be. If you feel that they have PVD and then it's due to diabetes, then that's what you would document.
Okay. Thanks.
You're welcome. Hello?
Hello. Hi. This is Rico from Community Life in Pittsburgh.
Hi.
Hi. I have a question. I'm a little confused about the macular edema and the gangrene, the with or without part.
Okay.
My understanding, and maybe I'm totally wrong, but even in ICD-9, when you have a with or without situation, if they don't document it, I had always thought that would be sufficient for the without, and then they only document it if it's present. Is that wrong?
Usually, no, you're not incorrect. Usually what happens is there are certain things, the guidelines state that there's a default. So in other words, it says that if it is not documented with or without, then the code defaults to automatically to without. However, what I'm saying is because of the fact that of ICD-10 being so specific and just the unbelievable increase in the amount of codes for the specificity, it is wise to document if you know that it is with, or specifically if you know it's with, definitely document with. But if you know that it's without, it's not a bad idea to go ahead and document without. If you don't, is it going to prevent anybody from assigning a code? No, it won't. But it's just best practice to document with or without.
Okay, that's understandable. Very, very quick follow-up. Have you ever seen atherosclerosis actually documented? That to me is one of, so that is, I mean, because our doctors are not in the habit of doing that, so maybe that's something we need to change. Is that a common, I mean, I'm not sure about, clinical.
I have seen it. Is it common? No. I have not regularly seen it documented as atherosclerosis of the extremities. I only see it documented as PVD, and that's fine. But if it needs to be more specific, and because actually I think one of the in ICD-9, I'd have to look in 10. In ICD-9, I think realistically it is suggested to be documenting atherosclerosis of the extremities due to PVD. But no, it's very commonly documented as just PVD or peripheral vascular disease. Every once in a while we'll see atherosclerosis, but not often.
Okay, maybe if I have further questions, I can email you and Dr. Shamp about the benefits of this. I think it may be beneficial if it's a higher HCC. So
yes,
okay,
absolutely.
Thank you.
Sure. Any other questions? Well, I think that might be all the questions. If by chance there are other questions, if you weren't able to stay on, of course, if you weren't able to stay on, I guess you're not hearing this right now. If you are not able to stay on any longer, please feel free to submit any additional questions or anything to, again, myself, alad at cpstn.com, or Dr. Shamp, rshamp at cpstn.com. Don't forget about your survey that will come to you in an email, as it did last time. And the next webinar, webinar 3, will be on CHF, hypertension, CAD, and angina. It is scheduled for Wednesday, August 19th at 2 p.m. Central Time, 3 p.m. Eastern Time. I would like to thank everyone for joining us today, and I hope that today's webinar was very beneficial. Thank you all, and I hope you have a wonderful afternoon.
Thank you.